Hi everyone, and welcome to the Digitodontics International Academy. It's our pleasure to meet again today within the 2023 edition of Digitodontics Webinar Series, which help to make the knowledge of digital dentistry freely available for everyone through a series of webinars that will be hosted and organized by Digitodontics International Academy. It's our pleasure and honor to welcome our guest speaker, Dr. Jose Rodriguz from the Guy's and St. Thomas National Health Service Trust, London, UK. During this webinar, Dr. Rodriguz will discuss the latest multi-modal digital impression techniques used to overcome challenges presented by patients with trismus. You will learn about the various tools and technologies available to help capture accurate impressions for this patient's population. Dr. Rodriguz is a consultant in restorative dentistry at Guy's and St. Thomas National Health Service Trust, and also honorary clinical senior lecturer at the King's College London. In 2000, he qualified as a dentist from the University Santa Maria in Venezuela, and in 2018 he was appointed as a consultant in restorative dentistry at Guy's and St. Thomas National Health Service Trust. His clinical interests include multidisciplinary management of complex clinical cases, removable prosthodontics, tooth wear, and dental implants. Since graduating, Dr. Rodriguz has completed a doctorate measuring the progression of tooth wear over 3 years. He has published more than 20 peer-reviewed papers, has held various academic positions in London, is an active undergraduate and postgraduate examiner, peer and grant reviewer, has lectured nationally and internationally. He has held various positions in dental committees. Dr. Rodriguz is actively involved in teaching and monitoring, has co-developed endodontic skills courses for general dental practitioners, and is active and involved in clinical research. He enjoys going to concerts, reading, and be fit in his spare time. So, Dr. Rodriguz, thank you so much for accepting our invitation today to be with us here. So just before Jose started, I would like to mention that you can leave your questions and comments on the Q&A part. And after Dr. Rodriguz finishes the presentation, he will be happy to answer all these questions. Also, we would like to mention that a certificate of CBT will be available for those who are attending about 70% or 75% of the presentations. This certificate will be, some fees will be paid about 10 years to issue the certificates, but it's optional. So without any delay, let us once again welcome Dr. Jose Rodriguz with us today. And Jose, please, you can share your screen.
Thank you so much for the kind introduction, Mahmoud, and thank you so much for the team at Digitodontics, and to you, my friend and colleague, for inviting me to share some of the work that I have been doing treating cancer patients at Guy's Hospital. So I am about to share my screen, so let's hope that the IT works. Give me 1 second.
Yes, it is.
Can you see my slide there? Yes?
Go ahead, yes.
Fantastic, excellent.
That's nice.
Excellent, thank you so much again, Mahmoud, for the kind introduction. So my name is Jose Rodriguez, and I am a consultant in restorative dentistry at Guy's Hospital, and I hold an honorary senior clinical lecturer post at King's College London. I work for both institutions. I am going to discuss with you today some of the work that I have been doing in vitro and in vivo to take digital impressions for palatal defects for patients who have a history of trismus. It is a work in progress. It is not finished yet, but I have had some exciting results that I wanted to share with you. I carry out a lot of my work within Guy's Hospital and Guy's Cancer Center, and this research has been kindly sponsored by the Royal College of Surgeons of Edinburgh. So this is the contents of my lecture. I will introduce a little bit of the NHS and what I do for work. And then I'm going to talk about some statistics about head and neck cancer, including treatment and sequelae of head and neck cancer. Then I'm going to present some of the work that some of my residents have been carrying out in vitro in utilizing multi-modal digital impressions for patients with palatal defects, and some of the pilot work that I have been carrying out in vivo, which is at the early stages, but with some good promising results, and also the future work that I'm planning on carrying out. So this is where I work. On the slide on the left, not the tall, shiny building, but the short concrete one, that is Guy's Hospital. Guy's Hospital is 30 stories high, and I'm based on floors 26 and 21. And next to us is the Shard, which is the shiny glass building that you see on the left of the picture. That's the tallest building in Europe. So I work for the National Health Service. National Health Service, for those of you who didn't know, is the 5th largest employer in the world. We employ 1.5 million people, and the National Health Service has a yearly budget of approximately 125 billion pounds. That means that the National Health Service delivers care for all patients, the 70 million patients in the UK, free of charge at the point of access. That includes medical care and some of dental care. Guy's and St Thomas Hospital are some of the oldest hospitals in the UK. The picture that you're seeing is Guy's Hospital. We're allied also with St Thomas Hospital, which sits in front of the Houses of Parliament. And we're one of the largest NHS trusts in the UK with a turnover of 2.6 billion pounds yearly. And we have 1.5 million outpatient appointments yearly. So it's quite big. On the slide on the right, you see the building with the color bits, the green, yellow, and red. That is Guy's Cancer Center. The National Institute for Health and Care Excellence a couple of years ago modified cancer care in the UK to have dedicated cancer centers. So rather than cancer being spread all over the place with different models of care, they have consolidated cancer care in dedicated cancer centers where all patients with cancer get referred there. So the Cancer Center for North London is at University College Hospital, and the Cancer Center for South London is at Guy's Hospital. So that is the building with the lovely colors that you see on the right-hand side. That is Guy's Cancer Center. So I work within Guy's Hospital and the Guy's Cancer Center. I represent my specialty is restorative dentistry, which is the UK is the only country in the world that has such a specialty. It's quite a strange one because we are trained in restorative dentistry in periodontics, prosthodontics, and endodontics with an emphasis on delivering care for patients with head and neck cancer, hypodontia, trauma, or cleft and lip palate. So we deliver all aspects of care, and we work with medics and surgeons coordinating all aspects of medical and dental care. So as a restorative dentistry, I attend weekly the head and neck cancer multidisciplinary meeting, where I sit with surgeons, speech and language therapists, radiology, oncology, clinical nurse specialists, and we discuss all patients at all stages of their treatment, either a diagnosis or after they have received surgery, at every stage. So then I am able to jump in whenever is required for us to carry out dental input, dental treatment, and support our patients. As part of that, I deliver multidisciplinary care for patients with head and neck cancer, and we formed a one-stop clinic that includes restorative dentistry, oral surgery, dental hygienists, dental clinical nurse specialists, and our residents who come and train with us. As part of my job, I also have an element of research and teaching as part of my affiliation with King's College London. So, in the UK, there are approximately 12,000 new cases of head and neck cancer in England and Wales per year. It is the 13th most common cancer in women and the 4th most common cancer in men. The survival rate is not great, as some of you would know. The survival rate is between 19 to 59% of cases, with around 4,000 deaths per year. The incidence has been increasing since the 1990s. A lot of it has been associated with risk factors such as human papillomavirus, smoking, and other risk factors. The highest incidence of cancer, of head and neck cancer, is in those patients who are over the age of 70. There are, of course, many types of cancer. There's squamous, verrucous, spindle cell, and salivary. But squamous is the most common type of cancer in the head and neck region, accounting for over 90% of diagnoses. As it encompasses the head and neck region, is an area of complex anatomy, including the mouth, pharynx, salivary glands, nose, sinuses. So there's a huge psychological and psychosocial impact in the treatment of these patients, who may be treated with either resective surgery or with radiotherapy, with all the side effects that I will discuss later on. This slide shows the distribution of head and neck cancer in the mouth. Pink is female, blue is male. And what we can see here is that most of the cancers in the head and neck region concentrate in the oral cavity, concentrate in either the tongue or the tonsil, with around 5 to 6% in the rest of the areas, including gum, palate, and lip. In the UK, we have very strict guidelines of what to do when a patient is suspected to have head and neck cancer. When a patient has a suspicious lesion, an urgent referral is made to oral surgery, oral medicine, max fax, or ENT, and the patient has to be seen. An initial diagnosis has to be done within 2 weeks. An incisional biopsy is made. Histopathology is confirmed. Once histopathology confirms that it is indeed cancer, the patient is brought into the MDM. The MDM is a virtual clinic that I was discussing earlier on, where we discuss a high number of patients. Over 2 hours, we may discuss anything between 30 to 50 patients, where the patient is presented, and any specialty who needs to input into that patient care has a say in it. And that's where I sit, and I sometimes say at diagnosis, I need to see this patient prior to surgery, or this patient is ready for rehabilitation. I need to bring this patient back to dental so we can help to support them. So treatment for head and neck cancer depends on the staging and whether the intent is to cure the patient or just to support the patient through palliative care. Surgery can be carried out with or without reconstruction. In this aspect, in this lecture, I'm going to be talking more about without reconstruction, because I'm talking about holes in the roof of the mouth. And patients can also receive chemotherapy or radiotherapy, and sometimes also immunotherapy. For cancer of the oral cavity, the treatment tends to be surgery primarily, with radiotherapy and or chemoradiotherapy. For cancer of the pharynx and larynx region, the treatment primarily tends to be radiotherapy or chemoradiotherapy, plus or less surgery. Surgery in the roof of the mouth can be, the defects can sometimes be reconstructed, but sometimes it is not possible to reconstruct them. It is not on the patient's best interest to reconstruct them, or sometimes flaps fail and patients end up with defects in the palate that then get rehabilitated in the UK by the restorative dentistry team, around the world by prosthodontists or maxillofacial prosthetics, by delivering a simple or complex obturator prosthesis that seal these defects and aid patients with function, swallowing, speech, and so forth. Defects can present, I'm sure all of you know Armani's classification and Brown's classification. Defects can present in a number of sizes, distributions with teeth on one side, no teeth on the other side, as you can see here, and also some patients who are edentulous. So when patients are treated with radiotherapy, when radiotherapy is indicated, there are some side effects that the patients can suffer from, and I'll discuss those later on. So when a patient receives radiotherapy, they are scanned to prime radiotherapy, and then they have a mask fitted where the patient is clamped into the table using this mask to deliver the radiotherapy to the tumor bed with high precision, to an accuracy of around 1 millimeter to either side. Radiotherapy can be external beam, IMRT, proton beam, also brachytherapy. That's very rarely used in the UK. For the vast majority of cases, IMRT is used. And there is 2 proton beam machines in the UK, one in North London Cancer Care at University College Hospital, and the other one in Manchester. For curative intent, generally 60 grays are given or above, and for palliative intent is around 20 to 40 grays. Generally, the patient receives 2 grays daily, Monday to Friday, then the rest over the weekend, and then the dose accumulates and they receive radiotherapy for 6 weeks. The picture on the left shows a typical mask that the patient he wears during radiotherapy to position them on the table. And the picture on the right shows an IMRT machine. So radiotherapy has side effects, as we all know. The early onset side effects is difficulty swallowing, mucositis with ulceration, alteration in taste, but also resulting in malnourishment, as a lot of patients cannot eat during this phase. So they're either PEG fed, or they are fed through nasogastric tubes, or when the patients can't swallow again, they may have to optimize their nutrition by using oral nutrition supplements that are very highly cariogenic, and some patients have to drink these drinks 6 to 8 times per day. So these drinks are highly cariogenic. So our role in the restorative dentistry is to make sure that we're supporting our patients during this journey. Radiotherapy also has some long-term side effects. Xerostomia, if the salivary glands are irradiated above 30 grays, you can have xerostomia, but also the saliva can change. There's reduced amount of saliva. The saliva becomes very mucus, and it also has a lower pH and has reduced buffering capacity. So of course, we lose the protective effects of the saliva. Compounded with the oral nutrition supplements, patients can end up having a fair bit of radiation caries and periodontal disease. Osteoradionecrosis of the jaws also happens in around 7% of cases, and also reduced mouth opening, which is where I'm trying to lead with this. When patients receive radiotherapy of high dose posteriorly for cancer of the tonsil, pharynx, hypopharynx, there can be fibrosis of the muscles of mastication, and patients can present with reduced mouth opening. And as we all know, patients presenting with trismus can be very challenging to treat. These patients who are treated many years ago had rampant caries, osteoradionecrosis, thankfully she did not have a palatal defect, but there was a lot of dental challenges that could have been prevented if she had received the appropriate counseling and treatment at the outset of treatment to help support her, so she did not get onto this stage. So the question is, when we have a patient with trismus as a result of radiotherapy or for other reasons, and they have a palatal defect, how can we take impressions of palatal defects with these patients with trismus? So there's a couple of research groups that have been doing some wonderful work on using digital techniques, and that includes Dr. Al-Bashti, of course, and there's a couple of groups in China as well who are doing this wonderful research. Using digital techniques such as cone beam computer tomography and also intraoral scanners, applying these technologies, which are now widespread and used everywhere, but to our patients with head and neck cancer. So what we wanted to do initially with our residents is that we wanted to carry out some validation in vitro work to see if we could create composite casts. Composite casts meaning that are made is a cast where we can make an obturator, but it's made with 2 techniques. So using cone beam computer tomography and an intraoral scanner or a gypsum cast, we can merge them together and you can get the best of both techniques. So I'm going to hopefully explain this. It's a little bit difficult to follow, I realize, but hopefully I'll explain this well. So we had a master model that has a palatal defect. I know it's not cancer, it's cleft, but it's a palatal defect for the purpose of the in vitro part. That master model was scanned with two CBCT scanners, a Planmeca CBCT and an Aquitomo CBCT. That master model was also scanned with two different intraoral scanners, a 3M true definition scanner, which is not used in the market any longer, but is still very accurate, and a Planmeca intraoral scanner. The master model was also duplicated by taking conventional impressions with silicone, which were poured in conventional dental stone, in gypsum. So what we did is to create composite models where the soft tissue portion came from the CBCT, and then the tooth portion came from either one of the two intraoral scanners or a conventional impression. And we mixed all of these techniques and we created what we call composite models, where again, the soft tissue portion came from the CBCT and the hard tissue portion came from either a conventional impression or the intraoral scanner. And we printed these casts. This is what we did. What you ignore this slide, these are what we did with the composite cast. So this portion here is a soft tissue portion. So it was either the Planmeca CBCT, Planmeca CBCT, Planmeca CBCT, or Aquitomo CBCT, Aquitomo CBCT, Aquitomo CBCT, merged with the tooth portion, which is the 3M intraoral scanner, Planmeca intraoral scanner, or gypsum. And then for the CBCT Aquitomo, it was again the TrueDef 3M intraoral scanner, Planmeca intraoral scanner, or gypsum. We created these composite models, printed them, and then compared them to the master model to see how they differed, how accurate or inaccurate they were. So each of these models, which is the composite models, was digitally superimposed into the master reference model using Geomagic Control 2014, which gave us a heat map, and we were able to measure the differences between the experimental model and the master model using 172 different areas. We could measure the differences quite accurately. These are the results. The results showed basically that all the combinations of techniques were as accurate as the gold standard gypsum. So CBCT Aquitomo with intraoral scanner TrueDef, all of the combinations were between 170 microns to a maximum of 260 microns. The deviations in the gold standard gypsum cast were 289 microns. So all the experimental models were actually more accurate than the gypsum cast, and these differences were statistically significant. Now, there are many reasons why the gypsum casts were not accurate. Gypsum is very easy for them to have a drag and a bubble, and that then skews your data. Whereas with a CBCT, an intraoral scanner, you reduce that risk. So of course, even though gypsum looks inaccurate, it is not truly inaccurate. You know, we've been using it for years. But what we demonstrated with this, is at least in vitro, these techniques were as accurate as the gold standard. So what we want to do is to bring this in vivo. And we had a patient recently who had no other option than to go through this. So we tested some of these techniques in vivo, and that's what I'm going to present to you now. So we had an 83-year-old male patient who presented with, who had hypertension, type 2 diabetes, rheumatoid arthritis, and ischemic heart disease, and a previous background of lichen planus. The patient presented with a non-healing ulcer on the left palate, and an incisional biopsy confirmed that this was squamous cell carcinoma. This biopsy was carried out in February 2022. The patient was referred to a one-stop clinic for an urgent dental assessment and impressions for a surgical obturator, as the patient was not going to receive a reconstruction. This is the dental panoramic tomograph. Not much to see here, fairly good level for someone who is 83. The tumor was located somewhere here. I think the thing to know, just a little bit of bone loss, an impacted tooth here, impacted tooth there, but this was going to be removed as part of the surgery. But then the thing of note here is this extruded lower left 3, which was going to make my life very interesting later on, and you will see when I show you the clinical pictures. The diagnoses were periodontitis, partially dentate, extruded lower left 3, and impacted lower left 8. So the patient was seen as an emergency on a one-stop clinic where a consultant-led treatment plan was formulated. Our hygienist carried out oral hygiene instructions and professional mechanical plaque removal. Our resident radios carried out a full mouth intraoral scan. They smoothed the sharp edges of the teeth, and they provided dietary and preventative advice. We prescribed the patient high concentration fluoridated toothpaste and fluoridated mouthwash. A dental technician carried out a surgical cover plate, and then a clinical nurse specialist takes over the care of that patient by carrying out telephone reviews on this patient to see when the patient is ready to come back to see us after treatment. So the patient receives all this package of care under one single clinic. These are pictures of the intraoral scans. The tumor was somewhere here, as you can see. So he was going to have a partial maxillectomy, and that's the lower scan. And these are the 3D printed casts. So the patient had a partial hemimaxillectomy in March 2022, and a surgical obturator was fitted at the time of surgery. The histopathology confirmed a T4N0M0 squamous cell carcinoma of the left palate, and the patient received no radiotherapy, no chemotherapy, and no reconstruction due to his age. 12 weeks later, our clinical nurse specialist called the patient to see how he was doing. The patient tells us that he is struggling a little bit to put the obturator in and out, and that he needed a little bit of help. So we brought the patient in, we removed the obturator, we adjusted it a little bit, we gave some physiotherapy exercises by the CNS, we showed the patient how to put it in and out, and he was doing absolutely fine. Now we measured that mouth opening then was 25 millimeters. But unfortunately, the patient then had a fall and spent 3 months in hospital. What happened during those 3 months is that he did not do his physiotherapy exercises, so mouth opening really got worse. So when we saw him in August 2022, mouth opening was measured at 12 millimeters. And he was, of course, struggling to insert and remove the obturator. We made some adjustments, some repairs, and then we referred the patient internally to our physiotherapy department for them to carry out more focused work on his trismus with him. But it didn't work, unfortunately, and when we saw him in November 2022, his mouth opening measured 6 millimeters. I'm going to show you a clinical picture now, so you will see why the extruded lower left 3 made my life a lot more interesting, rather than calling it difficult. And the patient then reported that his obturator was now not sealing the nasal passages. I think with adjustments, it was and scar shrinkage, the obturator was just not fitting really well. And that is the patient's maximum mouth opening. So as you can imagine, not impossible to take in impressions of this patient. 6 millimeters interincisal mouth opening, and this canine was making my life even more challenging. So taking conventional impressions was not possible. So we consented the patient, and then he agreed to have to go through the processes that I described on the in vitro side of things. So because we had an intraoral scan, the teeth had already been captured, and this was a godsend. Because we already had the anatomy of the teeth, which is fantastic. So what we did is we arranged a cone beam computer tomography to capture the palatal defects. And then on the intraoral scan, we did a surgery. So if this is the scan, so we superimposed them with CBCT, and then on the scan, we remove all the soft tissues. And then on the CBCT, we removed the teeth, and we created a composite cast that had the teeth and the soft tissues from the intraoral scan and the CBCT. So I'm going to show you how this was done. The first thing that you do is that you find common points between the intraoral scan and the CBCT, and the common points are going to be on the teeth, very simple. And you bring them into the same coordinates in space using Geomagic. So on the intraoral scan, I find 3 points. So the central incisor, canine, and molar. And then on the CBCT, I find the same 3 points. And then I use those 3 points to bring the CBCT into the same coordinates in space as the intraoral scan. So once that is done, I will merge them together and create a single composite file. What I will then do is that once they're both in the same coordinates in space, on the intraoral scan, I will carry out a surgical resection. That means I will delete the area that is marked in red, because that will be covered by the CBCT. On the CBCT, I will then delete the area in green, which is where the teeth are. And then when I merge them together, beautifully, I should obtain a composite cast where the black area comes from the CBCT and the rest comes from the intraoral scan, which is what we did in vitro. Now, I made that sound very simple, but this process takes time and resources. We needed a fair bit of hardware and software, including Geomagic D2P, which served to export the CBCT as STLs. We also used Geomagic Control 2014, which allowed us to do the superimpositions and the surgical resections. Exocad allowed us to tidy up the data and create the STL files for printing. And then, of course, we use a 3D printer then to create our composite cast. The first step was to clean and trim the data. So on the left-hand side, I am cleaning the data, and what that does is that it smooths all the sharp edges and smooths all the polygons. On the right-hand side, what I am doing is that I'm deleting the excess data that I don't need to aid in the superimpositional process. What that left me was with STL files which are ready for manipulation. On the top row, I have the intraoral scan and the tooth portion from the intraoral scan. And on the bottom row, I have the soft tissue portion from the CBCT and the tooth portion from the CBCT. So by finding common points between the teeth in the CBCT and the teeth on the intraoral scan, I was able to bring all the data together. So what you need to do is you need to find one point here on the intraoral scan, and then mark the same point on the CBCT, and then another point in the intraoral scan, and the same point on the CBCT, and so forth. So then the software finds enough areas in common to bring the two data sets together. And this is what it looks like. So on the top left, I have the intraoral scan, top right, the CBCT. I'm finding points in common. By the way, this video is speeded up, so don't pay too much attention to it. It's just so for you to see more or less what it looks like. This is speeded up. This whole superimpositional process takes a fair bit of time. So that's what you do. So you use those two scans, the areas in common, to bring the two scans together. Once you have done that, and they are both in the same coordinates in space, then I carry out a surgical resection where I remove the soft tissue portion from the intraoral scan and I remove the tooth portion from the CBCT. And then I create what I call my composite model. So what I'm doing here is that once that the both scans are in the same coordinates in space, I am then bringing the data sets together, and I am doing the surgical resection. So anything in red, I'm going to be deleting. So I deleted the soft tissue portion in the intraoral scan and the tooth portion on the CBCT in order to create my composite file. Just trimming data, adjusting data, just aligning everything together. Once that is done, I am ready to create my composite model. So on the left-hand side in pink, you can see the intraoral scan where I have done the surgical resection. And then the right-hand side, you see the CBCT where I remove the teeth. Both of them are in the same coordinates in space, and that's what they look like. Now, this is ready to be printed, but what I noticed is that the superimposition was not perfect because I have a gap between my intraoral scan and my CBCT that is not there in the mouth. And this is what put a little stop to where I was. I still went ahead. I'm able to fabricate a prosthesis for this patient, but I'm still doing a little bit of work to see why is it that we have this gap. But we still generated a model to help us. So that's in Exocad, we then created that fully three-dimensional sealed manifold model that we could then print. And when it's printed, it was a moment of great pride for us, and that's what it looks like. So again, just to remind you, this comes from the intraoral scan, this comes from the CBCT. The first thing that we did was to do a couple of pressure foam retainers just to see if it fitted prior to committing to anything too large. We fabricated a couple of pressure foam retainers, brought the patient in, fitted the retainer, and I thought, perfect, it sits well. So, you know, the data is not that distorted. But what we noticed was that there's a gap between the soft tissue portion on the left-hand side. So even though it's close enough, it still doesn't seal the defect fully. And that correlates very well with the gap that I was seeing between the intraoral scan and the CBCT. So what we did is that, well, we still have all of the digital resources. What can we do to support this patient? Well, on the cast, we fabricated a cover plate that does not go into the defect, okay? That has some clasps. That's the cover plate from the other side. The patient then, we relined it with Coe Comfort. The patient went home with it, and we took a functional impression of the defect with Coe Comfort. Then after a couple of days, the patient comes back, and we took this bung and we scanned it, and then we milled it. So this here is now this bung milled going into the defect in a biocompatible resin. What we are planning on doing now is that this is my milled bung that is sitting on the cast. We're using this to add some clasps to do almost an alter cast technique. So that's my lovely bung there that has been milled. And what we will do is that then we're going to fit this on the patient. Now, by sheer luck, this obturator is ready, and it was going to be fitted last week, but it was not. The patient is coming tomorrow to have this fitted. So I'm hoping that at my next webinar, I'll be able to update you all on how this fitted. So that's where we are at the moment. So on reflection, the preoperative intraoral scan was invaluable, was essential, because if we did not have that scan, we will be stuck because there was no way of taking impressions of this patient. So that changed our approach a little bit, that now every patient who comes at diagnosis has an intraoral scan, regardless of, because that means that we can always 3D print a model. We always have a baseline model that we can utilize in the future. We can also use those STL files when we do implant planning to retroplan to the patient's original dentition. So it changed our model slightly. If you don't have access to an intraoral scan, my advice is still take an impression, but scan it on a lab scanner. So you always keep the STL file. There's nothing more disheartening than your only master cast in gypsum falling on the floor and breaking, and then you're stuck. Just scan it, keep it, digital copies, so you can always print a new cast. The superimposition process was hugely time consuming. That took me 8 hours, all of that work that I did on Geomagic. Maybe it will take me less time as I become more familiar with the system, but I did not, because I used this software during my PhD a lot, and then it's been a while, it took me 8 hours to do that work. I'm sure it can be done quicker, but you need people power for this. Now, the CBCT may not have been the best tool to utilize, as the way CBCTs are taken, they can generate a lot of scatter. So other research groups have used CTs, which is absolutely fine, but justifying a CT of the head, we have very strict radiation regulations in the United Kingdom. So we would have to make sure that the benefit that we're getting by the increased radiation is going to be beneficial to what we're trying to do. So CBCT may not have been the best tool. We just need to see how better could we get a result by using a CT. Now, the fit is not perfect, but it can be relined and it can be adjusted, and it got us out of trouble. And we were able to give the patient at least a provisional obturator now that the patient can function with, can insert, can remove. Now, I'm hoping that the obturator that I'm fitting tomorrow is going to be well fitting. So therefore, all these digital tools really can help us manage these patients. But teamwork was essential, and I'll show you later on all the people that were involved in making this possible. Now, where are we going next? So we are going to try and validate in vivo the role of the defect and the tooth setup in the superimposition. By that, I mean that in this defect, is similar to what the clinical cases are presented, where you have teeth only on one side. If we have teeth only on one side, you may end up with that defect that created that gap, and then the superimposition was not entirely accurate. What we want to find out is whether in vivo, having teeth on either side, so your superimposition is almost triangulated, so your defect is surrounded by reference points, as we did in our in vitro work, we want to see whether this makes any difference, makes any improvement in our clinical technique. So that's where we're going. And then the next stage with this is to validate the accuracy of frameworks produced using these composite models, because what we want to see, well, this is all well and done, but can we produce Chrome frameworks that fit here? Can we save patients time and appointments and clinical time by producing well-fitting frameworks? And there has been a little bit of work that shows that using these composite techniques, we can produce well-fitting Chrome frameworks, but I really want to bring this now to an in vivo scenario. So that's where we're heading. So I talked about teamwork. We have a fantastic team at Guy's and King's College. Our patients have been wonderful to us, hugely supportive of all our projects. My fellow consultant, Poonam Kalsi, our registrar, Sapna Patel, who's training to be a consultant, our residents, Dima and Noor, who carried out most of the in vitro work, Polly is our PhD, one of our PhD students, Kate, our clinical nurse specialist, Caroline Reed, our maxillofacial prosthetist, Peter Ashel, who did a lot of the work on exocad, Simon Coyd, who was a very talented removal lab technician, and of course, the Royal College of Surgeons of Edinburgh for their kind financial support. Now, I am always open to collaborate. I'm always open to discuss. I love being challenged. I love when people emailing me saying, I thought of this, can we do this together? Or your work is rubbish. I suggest that we do this, or do you improve? So please feel free to email me, contact me. I'm always happy to hear any suggestions, any criticisms, and I'm always happy to collaborate with any future work. Thank you so much for your attention, and I'm very happy to answer any questions if you have any.
Thank you so much, Jose. It was very interesting that you introduced us to, I should say, it's a hybrid technique that using multiple digitizing resources to overcome an issue that many of us facing when we treating patients that exposed to radiations, and they have some issues regarding the mouth opening and trismus. So thank you so much. I really appreciate the time and effort that you done to reach these results from your in vitro and vivo results, and hopefully that tomorrow the patients can go back happy.
I'll be sending you a text with thumbs up. Hopefully you're going to get a text from me saying, and you can then email the group if you want to say,
okay, that's great. And I really like the point that you know, sometimes some clinical issues raise some flags, and I think this case raises the flag that you need to take an intraoral scanner before and keep it at the clinic. And that's very, very key point, you know, because as long as you have a library for your patients, that will save your time and many issues that can be happen.
Absolutely. And also, as you know, we are, so one of the Professor Michael Fenlon, who is a legend in cancer care in the UK. He retired a couple of weeks ago, and we've taken over a lot of his cases. And there are these patients that he's treated over many years that are very complex, and we're finding that these patients come with casts. We normally give patients their implant cast and say, well, you're going to look after them better than us. So what we do now is that when the patients bring the cast to us, we scan them. So we keep an STL file on them just in case that's ever lost. Again, we have a copy that can just be printed at any time. And that is one of the things that we've noticed, and it's really changed our practice after going through this case, is that having access to a forever digital file can really get you out of trouble in the future.
Yeah, exactly. So attendees, please don't try to write down your questions. It's a good chance to have your questions answered by Dr. Rodriguz. His expertise in this area. So please, if you have any questions, just write it down. Jose, as you mentioned, when you're dealing with a case that needs, or you choose a digital treatment to follow, that's kind of time consuming, especially for those who need, highly skilled people to help them, and sometimes it's difficult. So how could you manage to do that?
Well, it's interesting. So there's two elements of this. So I work for the NHS. So in the National Health Service, my job in the National Health Service is to see patients, is clinical care. So what we have done, guys, is that we have appointed a digital lab lead technician whose job is to push the digital aspects of care. So he is very well trained. He deals with he maintains the scanners, maintains the haptics, sends stuff for 3D printing, and then his role is to train all the other technicians. Now, from a research point of view, that's where it's a little bit of a gray area, because the NHS cannot really afford to have someone for 8 hours sitting on a lab and doing a superimposition with Geomagic. But what we have done is that's where our residents come into play. So a lot of this work is generally carried out by our residents, because they get a fantastic dissertation from it. They get experience in using a software that actually some of them have purchased in their own countries. And also we get an element of service delivery. But I believe you have worked with Geomagic, haven't you? Yeah, you have worked with Geomagic.
Yeah.
It takes time.
Yes, it is.
It's time consuming, and but the benefits that you get from being able to treat a patient and help a patient, I don't think you can really quantify an improvement in quality of life, can you? So it's an investment. I think it is priceless. I personally, I don't really have a lot of time for research. As I said before, my job is service delivery. In order to do the superimpositions, I take a day off. I cancel a day of practice, and I sometimes come on a Saturday, and I sit with my residents and I do this work for them, because I'm quite passionate about the results that we're achieving. And the fact that we are applying, everyone gets happy about scanning implants and scanning dentures and 3D printed dentures, and everyone tends to forget the cancer patient.
Yeah.
What I'm trying to do is that, well, actually, no, there's a lot of this stuff that we can just get creative. I mean, delivering maxillofacial prosthetics is so complex that you need to innovate, you need to create, you need to be creative. And by just bringing all these digital tools into these patients, we realize, actually, this could really benefit our patients. So it's worth spending the time and the resources on this.
Yeah, I totally agree. I mean, yeah, in some cases, it takes long effort and time, but you will learn from that, and you can set up the next steps for the other patients. It becomes more easier, because you got everything for that.
Yeah,
so that's fantastic. So I think the attendees is a little bit shy. I don't know why. Okay, so
everybody's shocked. I explained that very well, or everyone is in shock. I am very happy to answer any questions by email. As I said, please make a note of my email on the screen. If anyone is being shy and they want to ask any questions or make any suggestions, very happy. I operate an open door policy. It may take some time to reply, but don't worry, I'm here.
Okay, fantastic. So I think we are going to conclude our session today. I would like to thank you. Good. So as a tradition for Digitodontics, we would like to present you a certificate of appreciation. So we hereby express our sincere appreciation to Dr. Jose Rodriguz in recognition of his contribution as a live webinar speaker for Digitodontics Webinar Series on the topic of multi-modal digital impressions techniques for patients with trismus. That was presented on Thursday, May 11th, 2023. Jose, we would like to thank you very, very much for everything that you shared with us today. Thank you.
Thank you so much, Mahmoud. It's been an absolute honor. Very happy to share my knowledge with you. And thank you so much for the invite. And I look forward to coming back to this platform again.
Thank you so much. Have a nice day.
And thank you so much to all the attendees. I hope you enjoyed it.
Yeah. Thank you, everyone. Thank you to all attendees for coming today to have a look to this exciting lecture. And don't hesitate to come back to the upcoming webinars. We have many exciting webinars coming ahead. So please come again and so these webinars. So see you on the few weeks. Okay, take care, everyone. Bye-bye.
Thank you.